Good morning. So this morning, I want to talk about a very interesting topic to me, and that's something I have some experiences and that's weaknesses in dental research. We're going to talk about this here because it really underpins what we do as dentists. The expectation of following evidence is not as strong in the dental field, and the evidence itself really is not as good as it is in medicine in particular. And let's talk about why that is and what the impacts are. So, the agenda, first of all, we're going to talk about some of the problems. Really, what we do is we rely heavily on benchtop in vitro studies. There's a lot of methodological flaws in how we do our studies and how they can be combined together. There's an incredibly slow adoption of evidence, and research silos within dentistry are real. We speak our own language, and other people that may be able to solve the issues that we need to solve aren't able to look at our evidence. And it really is structured in such a way where industry plays a huge role in the types of studies that are made, um, and they influence perhaps even the results of those studies. The studies are underfunded in themselves, and the studies that we do often drift away from the types of questions that we need to answer as clinicians. And we're going to talk about the impact of that and maybe some of the ways we can improve it. So, first of all, we rely heavily on laboratory studies, and I've done laboratory studies before. The wonderful thing about laboratory studies is they can be done very quickly. So, if you're trying to publish results, this is a great way to do a lot of papers and collaborate with a lot of people quite quickly. But for a lot of different types of materials that we work with, composite based materials, 3D printed based materials, bonding agents, they change a lot after they've been in an aqueous environment from a certain amount of time, or after they've been stressed or continually heated and cooled. They tend to degrade. So these benchtop studies are a poor representation of clinical outcome. This bench to bedside disconnect, so called. So they may look great. You may see a wonderful rack and stack of a certain material compared to others, but if you don't do clinical trials that are incredibly long, which take time, you're not going to really know how effective it is. So the solution, you can't abandon it. It really has a role, but you also really have to study it long term. So there's a lot of flaws too. These studies are often very small. There's an average of only 37 patients per trial, which is, again, just not comparable to larger studies you may see in medicine. Studies are short there, and there's an incredibly high risk of bias within dental studies. P-hacking is certainly possible. Where we're using basic statistics, it's certainly easy to find a particular statistic that is comparable if you're looking at multiple. And the method is the randomization, the blinding, the statistical power, the techniques used often isn't there. There's just a lot of fairly low quality studies. And the result is that when you try to do a systematic review of everything, you can't really make up any incredibly firm conclusions. So, and nearly half of studies are really just not that good. They may be biased. And the result is dental literature is completely full of contradictory findings. One person says one thing, one person says another, and they may find a finding in one study, and then in another, they can't find anything. So you can't reproduce these studies. And ultimately, this means there's not a lot of confidence in dental studies. A lot of dentists follow their intuition. Now, the oral disease is incredibly complicated. We're looking at an influence of a lot of factors that other scientific fields can speak to much better than we can. We're looking at bacteria, diet, genetics, inflammation, not just oral hygiene, but we don't necessarily speak that language. We may speak the language of dentistry. We talk about missing teeth. We talk about bleeding on probing. We talk about apical periodontitis, but we don't translate that to a larger field. So other disciplines can't necessarily help us. And oftentimes we may test an adhesive bond strength in idealized conditions, but we don't look at the larger picture, especially, and this is especially true of in vitro testing. The adoption of evidence-based dentistry, unbelievably so, 17 to 24 years. So even if there is good science, we often don't read it or use it. When I was in my residency, we were able to shadow some of the medical residents at an internal medicine department at Keesler. And you better believe, one, they would have a study. When a study came out, a recommendation came out in a reputable journal. One, it was incredibly high quality. And two, they were expected to know it verbatim within months or weeks. It wasn't 17 to 24 weeks. So they're on it in medicine, but that expectation is really not there in dentistry. We have a worker as it works in my hands. You see it all the time. So again, works in my hands. There's cultural barriers where we trust cultural experience much more than research findings. And that is ripe for bias. Our intuition is not incredibly strong. And we're just busy. There's a very large amount of dental journals. Many of them are pay gated, and they're also divided by specialty. So it's very difficult to continually get the latest information. And a lot of that information is not really clinically relevant. It's low quality. It's difficult to read. It's difficult to get through. It's contradictory. So it becomes difficult to be a research-based scientist. And when you look at not formally trained, the people doing the research don't necessarily even know how to do it. So let alone the people that are actually reading the research. So there's definitely a bias where people just want to read stuff that confirms what they already know. And that becomes a big problem. So the evidence app, and this was a Gordon Christian statement, 8% of estimated clinical practices is actually based on peer-reviewed, critically appraised evidence. Very low. It's not a true statistic. But what is true is that it is most likely the issue is that people don't follow what we already know. So the issue is more that people aren't talking about good evidence that's already out there. Making more evidence or a lack of more great evidence isn't necessarily the problem. It's an adaptation and an ingestion of what's already out there. And we're publishing more and more now. And dental research is in a silo. When you look at, they did a bibliometric analysis, and 85% of dental journals reference other dental journals. They don't branch out. It's only 14 to 15% cite work in medical or basic fields. And this is a big issue, especially now that we're doing more and more surgery, grafting, because there's other fields of medicine that have incredibly advanced and well-established protocols on how to grow bone, how to do implants. And we're not borrowing these techniques and bringing them over to dentistry. And we may have incredible insights on how to deal with biofilms, how we deal and cause healing within people and how to treat people that aren't being translated back to these various fields. And part of it's that we don't speak the same language. We're still talking about bleeding upon probing, loose teeth, mobile teeth, furcation involvement, stuff that people don't understand. We're not actually looking at the root cause of the problem, which is a biofilm. So the result is dental research, by not asking questions, by expecting, periodontists think they're going to solve all the perio issues in dentistry by themselves, they don't speak the language, and they're not asking people in other fields, computer science, statistics, mathematics, to help them solve these issues. And the result is the problems just accumulate, and we really don't have any new solutions to a lot of these things. Our research moves forward at a very plodding pace. And these dental findings, dental questions aren't actually penetrating out of dental literature. They're not getting in other publications that other people might want to read. The cross pollination just isn't there. So, very, very smart people outside of the dental field could probably offer us incredible insights, but just aren't being asked or aren't aware. So, there isn't a connection, particularly, obviously, within the medical community. The oral link between overall health isn't as established as it should be. It's incredibly influential, but the lit isn't there. The crosstalk just isn't there right now. There's other industries too. When you look at industry, when you don't have a lot of funding, a lot of dental studies, especially for new medications, devices, and stuff, are sponsored by the companies that make those products. And it's no surprise. We all kind of know it, but they've actually studied it. Industry funded trials are much more likely to provide favorable results for the sponsored product. We see 100% success rates for implants. Of course, the company sponsored that trial. And what this means is you see a disproportionate amount of research on products that can make money. Bonding, the upsell on bonding agents is huge. So you see a lot of research come out on bonding agents. Dental resins, you'll see research come out on those. A lot of it's in vitro studies that will rack and stack them, and all of a sudden one is doing much better than all the others. And you really can't always hang your hat on a study like that. And areas that aren't getting as much resources or attention are prevention strategies. Fluoride, in-office fluoride, various ways to actually prevent cavities, public health measures, addressing oral health disparity. I mean, you got to figure out, I hate to say it, but a lot of dental disease is caused by sugar and tobacco. And that's not an industry that we really tend to go head to head with. Now, when you look at underfunding of dental research, it's very low. In the United States, 1.1% of the National Institutes of Health go towards dentistry. So when you figure it's the insurance industry is about a $70 billion industry, and the dental industry itself is about a $120 billion industry, roughly. So altogether, you're looking at roughly a $200 billion industry, and it spends less than $500,000 a year on research. So that's incredibly low. And a lot of that money does go to dental schools, Australia, and internationally, it's the same thing. There's just a lack of investment. And the result of that is you don't have a large amount of clinical trials. You're not really asking, or you can't bring people in to answer fundamental questions. And ultimately, if you can't get a funding source, scientists, there's a business within research. And if you can't get funding and publish in a certain field, you're going to find a field that you can. So you're going to definitely have a talent drain of talented researchers are just going to leave the dental field if there's not enough resources there. And ideas really aren't tested in this area. So really patients suffer the most. So that's what people say, dentistry being an orphaned field where it's vital for health, but it's just been neglected. It speaks its own language. It has incredibly difficult questions that, again, aren't being answered. So it's not being funded appropriately. And to show, we can't really show a payoff on that. So academic drift is another problem where all of us As a dentist, as a clinician, there's questions I want answered. What is the best way to prevent this problem? What is the best way to treat my patient? What is the best bonding agent to use? What is the best protocol to use? And nobody will come out and say it. And in fact, the problem's getting worse. There's applied dentistry journals that answer clinical questions, and there's less publications in that, and there's more publications in more basic science journals. So they're not, people aren't asking or answering the difficult questions. They're answering the questions they can get funding for. And in many instances, there's a big difference in that. So they're moving away and they're moving towards this basic sciences. And obviously, this is a problem in academia, where there's a mismatch between the questions that dentists need every day, the types of questions, and what's actually being offered. So the consequence is, again, there's more, the knowledge flow from the scientific community is not necessarily coming back towards dentistry. And it's tilting away from practical problems. And we're not necessarily bringing in lab discoveries and new materials and new ideas back towards dentistry, where we're really relying on the dental industry for that. We're relying on corporations to try to bring innovations to us. So a lot of the work that academics are doing, it may be influential, it may be found in publications, but it's not geared to actually help dentists, or in that manner really help patients. So there's a feeling, a lot of stuff when you read dental journals, a lot of it doesn't feel particularly relevant to dental practice, and that becomes a big problem. One example is almost 30 years ago, there's an older periodontal classification. And the advantage of it was aggressive periodontal, chronic periodontal disease, generalized, localized. And it was okay, but it wasn't necessarily standardized. It was difficult, and it didn't really reflect the risk of the progression of the disease. And that's really what they did in 2017. There was a global classification system that was able to look at various factors, smoking, diabetes, the progression. So it was able to stage it where it would give the clinician an idea of how fast it was likely to progress. And this was a very good idea, but the problem, it was very clunky, very complicated, and it's still not even considered to be the standard. Plus, insurance companies don't necessarily require it, and they really dictate. Insurance companies, unfortunately, Delta Dental in particular, doesn't seem to care about science, and they're very old-fashioned in what they do and what they require, and they essentially shape the industry. So there's a lack of standardization with this. And the result of this is you often can't compare or pool things together. And another thing is the decayed, missing, or filled index. This is invented in the 30s, and it's an attempt to standardize how we do things as dentists, but it doesn't really work. It's decayed, missing, or filled teeth. That's a very relative amount, and it doesn't necessarily capture the full extent of what's actually going on, where there's much more nuance. Where is the cavity huge? Is it very small? Is it a pre-cavity? You don't necessarily get a very good idea, especially on a young patient, how effective it actually is. And the result of this is there's a limited adaptation of very advanced methods, where there's something called a networked meta-analysis, very common in medicine. And what that means is you run a study and everything is run the same way. So if you do every study the same way, then you can subsequently compare them all. So that way you can compare, the effect of one bonding agent with another bonding agent, even though they weren't even in the same study head to head. And this is very, very useful when new things come on the market, because you can test a new bonding agent with an old bonding agent continuously, and you can really track an evolution of materials, and it'll make it much, much easier to make sure that we're continually improving. Kind of like a Bayesian statistic type idea. We're beginning to start to standardize outcomes, but and I'm going to foot stomp this again. A lot of dental outcomes are furcation involvement. It's stuff that is specific to dental. They don't necessarily look at things that might be influential in immunology, like how much inflammation is in the gingival tissue around a tooth. Are there any biomarkers in the saliva? They don't look at that. And the problem is it becomes difficult for other people outside of the dental field to help answer these questions because they're not universally applicable. It's just not good data. So obviously we've been very slower to embrace these sort of evidence based statistics compared to medicine. If you do something in medicine, oftentimes there's a beautiful flow chart that establishes the decisions that you need to make for virtually any condition, and your best practices are spoon fed to you. In a lot of ways, medicine's a lot easier than dental. In dentistry, we don't have that, and you have to rely on experience. And almost every dentist has to figure it out for themselves or ask a senior colleague. And this is obviously a huge issue. There's been some progress, we are establishing these core outcomes, but once again, we're not establishing outcomes that other scientists can really understand. There's still dental outcomes, and we haven't figured out how to extend it in many instances. We're starting to use network analysis. We're starting to classify things better. We're starting to recognize the importance of universal collaboration. And there are more sophisticated statistical and measurement tools that are coming out there. But the problem is if the dentist can't necessarily interpret them, like a logistic regression or something like that, then it probably isn't going to be that useful or influential to the broader community. So hopefully modernizing the dental research toolkit is going to help cut through the confusion and get answers to clinicians faster. Obviously, the influence for patients is very often care and treatment planning is very inconsistent. And the types of materials we use, how we treatment plan a case, the types of data that we look at is incredibly, it really is just all over the place. And various ideas are very slow to enter the picture. Even if they weren't, they're often not used, where there may be certain types like chlorhexidine scrub underneath caries. Seems to help. There's a lot of good lit on it. Most people don't use it. And the expectation there as a dentist isn't that you always follow best practices. So the result is there's a fairly poor integration, and we often don't follow the lit that's already out there. And this is becoming more and more relevant because there is a connection between the oral cavity and systemic health. I've talked about this before, where the mouth is the gateway to the body. It harbors billions of microorganisms that can sort of wreak havoc in other parts of the body if left unchecked. Very simply, plus it can make it very hard to eat, which has a variety of trickle-down effects. So there is a bidirectional influence of all this stuff. So if we continue to keep dental research siloed, people aren't going to help us, and we're not going to be able to actually provide meaningful insights towards the greater scientific community. Now, oftentimes guidelines will say, hey, we don't have good science, or do I need this? Is this just a fad? And we can't necessarily stick to that if we haven't run a study that is strong enough to to tease out statistical differences between different treatment modalities, that is a problem. So the solution, and there's a lot of options. Obviously, we need to be better at not just relying on lab research, doing more clinical research, following the results of that good clinical research, especially when it's very, very strong, standardizing how we do things. We do need better methods. There should be greater agreement within the scientific community on whether these things help. And part of the reason is there's so much industry influence on these studies and standardizing how we actually do dental tests. And I would recommend also looking at outcomes that are more easy to interpret for people outside of the dental community. Obviously, the idea is to start breaking down the silo. We do a lot of research. We do a lot of surgery. It's a doctor of dental surgery after all, but we don't necessarily follow best practices established in other surgical guidelines. And we sort of have our own way of doing things. And that's a problem because there's incredibly advanced research on grafting and bone that we don't necessarily follow. So, we need to start talking to other people outside of dentistry, start fostering more relationships, and hopefully we can start publishing or at least asking questions in other journals that aren't dental journals. And I would love to see where dental care is not just expected to be founded on high quality evidence, but as that evidence comes up, it's continually integrated. There's not this 17 to 24-year delay before it gets actually integrated. So it really should be part of the oral health sciences. It's incredibly influential. I would love to see more interaction, more help from people on the more pure science fields, computer science coming into dentistry and seeing if they can help us answer these questions because we have a wealth of data. We have 3D scans, we have jaw motion data, jaw tracking data, we have biofilm, scans of biofilms, computer-based tomography, all incredible amount of digital data that really isn't being analyzed. So it would be wonderful to have someone come and help us take this to the next level. And I think we can treat patients much, much better. And to do that, obviously, more money. It's a chronically underfunded topic where virtually everybody in the world either has a cavity or at some point in their life will have a cavity. Periodontal disease is huge. It's 1 in 3. It's a global problem. Sugar consumption is actually on the rise. So cavities aren't going away. Oral health is not becoming anywhere near solved, and just drilling and filling probably isn't going to get us there. So we need to start looking and establishing policies that really help the industry as a whole and ask better questions and get better evidence. So that's all I have to say about that. Obviously, we'll do this again tomorrow. I'm going to try to restream this very soon. Anyway, thanks. Follow. I'll be back on Monday and we'll do this 6 a.m. every day. Thank you.